Good morning.
Thank you for joining us today. This is our 2018 first inaugural, I guess that's a kind of redundant word, Community of Scholars meeting. We took a kind of a hiatus last year with the transitions. So we're coming back with lots of speakers, lots of topics this summer. And this year we're going to have some things that are going to be professional development like this. We're going to talk about some course activities, what's emerging in the world of academia. So we have a kind of exciting year planned. So I am very pleased first to introduce to you Dr. Lisa Roberts. Now, Dr. Roberts is distinguished in a number of ways. Her background is fascinating, but she's a Western U alumni. She's an FNP graduate of our program. We won't say what year. And then she went on and became Doctor of Public Health over at Loma Linda. And that really cued her between her background and her academic preparation to go into this journey of global health. And she stumbled practically into this topic of perinatal loss with some of her clients that she saw. So I'm going to let her unfold the story and unfold her journey of global health from the lens of the perinatal loss. So please join me in welcoming Dr. Roberts back to Western University.
Thank you. It's wonderful to be here. It's been a while since I've been on the campus, and wow, what a lot of changes. You guys have grown a lot, and I hear great things, and so it's really a pleasure to be here. Thank you so much.
Okay. No one there. Gabriel's talking.
No, that's just she's speaking.
Okay.
It just gave.
Oh, okay.
Are we good? Okay. All right. So, first of all, I don't have any. I don't have any conflict of interest to declare. Some of the studies that I'm going to be talking about have had a bit of small funding, which I will share with you. I do want to acknowledge my co-investigator, Dr. Susanna Montgomery from Loma Linda School of Behavioral Health, who has been my co-investigator on a number of studies that I'm going to touch on. And she's also been my mentor in this journey. But most of all, I want to acknowledge that I couldn't do this work without local nurses, the participants of whatever study or program we're doing, and the key stakeholders in each situation. So I am going to discuss perinatal loss a little bit and some of the cultural adaptations that I've undertaken in some of my studies. But I also want to talk about how this all began and kind of the process of this journey, developing a program of study, and sharing some of the lessons I've learned along the way, because you just never know what you're going to run into. So by way of background, I have been kind of all over the world. I was born in Italy, stayed there till I was a young child. Then we moved to India. I was raised there. So India is near and dear to my heart, and I have lots of friends there. But I went to an international boarding school growing up, and so I have friends all over the world. And so I keep in touch with them, and that has opened some unexpected doors, and I'll tell you about that. But I always get the question, well, you're not Indian. Why are you doing research in India? So that's why. So a little bit about India. It is a very diverse country. The land mass is about 1/3 the size of the US, but it's the second most populous country in the world, as I'm sure you know. But the people themselves are very diverse. We have the equivalent of Silicon Valley. We have rich agricultural areas. We have rich history of back into the Mughal times. That's, where the Taj Mahal was built, etc. And in each area, the people have their own subculture, their own language, their own foods, their own style of clothing, etc. So it's really like a lot of mini countries joined together. And you have very, very powerful women. I mean, I'm sure you're all familiar with Indira Gandhi. We have women in the military and the police force. But I focus on very, very poor women, primarily in the rural areas. So you'll hear me talk a lot about that. But I don't want to skew your view of India, because what I talk about is just a slice of India, not the whole picture. So, in general, the societal values of India are very patriarchal, and for good reason. The sons of the family inherit the property. They are the only ones that can do the last rites, the funeral rites for the parents. So, you know, it's just gone on generation after generation. But that does have an effect on the society. Women are expected to give birth within a year after marriage, traditionally. That's changing a little bit in the urban settings, but in the vast majority of the country, that's still the expectation. And a woman's worth is based on her fertility, and especially whether or not she has a son. You've probably heard of son preference, and it goes back to the history that I just mentioned, but it also sets up gender discrimination. So unfortunately, sex-selective abortion is very prevalent. With today's technology, women are able to have ultrasounds to determine the sex of the child in utero, and are often coerced into aborting the child if it's a girl. So that has kind of replaced the female infanticide that used to happen. Mind you, this technology is outlawed, but it happens everywhere. There are also honor killings. That still happens today. Lots of abuse of every form. Just a couple of years ago, you probably heard the news that a woman leaving the movies one evening got on the bus with her companion and was gang raped and thrown out of the bus to die. That sort of thing hits the headlines once in a while, but happens much more often than you ever hear about. So there are a lot of issues pertaining to women that need attention. Well, while I'm trying to get this to click, you can read this quote, which I love. All right, what am I doing wrong?
So you keyboard.
Is it frozen?
Do you want me to get Gabriel?
Oh, okay. Cool. That's okay. I can just get it that way. That's fine. So, as I mentioned, India is the second most populous country, and less than 50% of the population is female because of that gender discrimination that I talked about. The female literacy rate is lower than men's, but this is a national average, and I gotta say, in the rural areas among poor women, it's more like 20%, because the girls only go to school until about 11, 12 years old, if they get to go to school at all. So the maternal mortality rate is 107 per 100,000. IMR, the infant mortality rate, is very high, as you can see. And the stillbirth rate is 27 per 1,000. But again, 1,000 live births. But again, that's a national average. I haven't seen anywhere lower than that, even in metropolitan areas, but I have seen much higher than that. In fact, where I've done a lot of research, when I first went there, the stillbirth rate was 330 per 1,000. That's actually what got me started. So a friend from my school days in boarding school runs a small hospital in this rural area. And I've kept in touch over the years, and I get the hospital newsletter every year, the updates. And when I read that, I thought, oh, that can't be. That must be an error. So I wrote an email to my friend. I'm like, are you sure? Because da-da-da-da-da-da, you know. And he says, well, no, we had a visiting physician from Denmark who actually discovered this. They had never looked at those stats before. And so I said, well, what's being done? He said, well, the doc from Denmark went back to his colleagues and they raised some money and sent a baby monitor. So what happens is these women are out in the village, in their homes when they go into labor. They're expected to give birth at home and don't come to the hospital until they run into a problem. Maybe they've been in labor for 2 days already when they come to the hospital. And since that time, which was in 2010, when the rate was 330, they've trained their physicians in emergency C-section. And with the monitor, the first thing they do is put the monitor on to see if the baby has a heartbeat or not. And so that has brought the stillbirth rate down at this hospital to 100. But it's still very high. There are a lot of government programs to address the cause of the stillbirths. So what I focused on instead was the aftermath, because unfortunately, no matter how many programs the government has to get the women to come to the hospital for birth and to have prenatal care, etc., these women don't have enough autonomy to choose to make use of those programs. It is up to the husband, the father-in-law, etc., and the mother-in-law, because these women live in an extended family situation. So she gets married, she leaves her family that she's grown up with. She might never see them again. And she is an arranged marriage, goes to live with this new family, the husband, his brothers and their wives, his parents, etc. So it's all his side of the family. And the youngest daughter-in-law has no power whatsoever. So if all the men are out, it's up to the mother-in-law to decide. And she says things like, it was good enough for me, it's good enough for you. We're not going to spend money to take you to the hospital, you can give birth right here. Usually they are attended by a family member, not even a lay midwife. So that's kind of the backdrop. And so then, as this was for my dissertation, I decided this is what I was going to look at. And as I began my literature review, I discovered that in the Indian medical community, they don't consider the aftermath a problem. Just get pregnant again. Just have another baby. So they'd have nothing in place for when a stillbirth happens, any immediate care of the mother, the family, anything like that. They're just expected to go on with life. And it actually revealed that the view is grieving for a stillbirth is a Western phenomena. So soft Westerners who have a cushy life and can't deal with tragedy because they have such a privileged life. That I was actually told that by a physician. And I said, I hate to argue, but I think a mother is a mother is a mother, no matter where she is and no matter what circumstances. But I needed to collect the data and see what it told me. So that's what I did for my dissertation. There are a lot of risk factors for stillbirth in this context. Maternal malnutrition starts from when she's just a young girl, because the men and the boys are fed first and better quality of food. The women and girls eat what's left or only rice. So by the time she's of marrying age, she is small. I'm considered quite a large woman there. So, I mean, these gals out in the village, they might be as tall as me, but their hips are like this wide, and they're about this big around. So you can imagine there's a lot of obstructed labor that occurs, and that is the #1 cause of stillbirth in this area. So no matter what the mother does at home, she cannot birth that baby. Also, because they're married very young. Now, the law is they have to be 18 years old to get married. Truthfully, most of them don't have birth certificates, so there's no proof of their age. So once they reach puberty and are menstruating regularly, they are considered marrying age. So when they get married, 18 is written on the marriage certificate. Who knows? They could be 15, they could be 16. And the grandmothers, they readily admit, oh, I was 13 when I got married, you know. But now because of the law, they all say they were 18, but, you know. And then because of son preference, they keep having babies as long as their reproductive cycle will allow, because if they haven't had a son, they are at the bottom of the barrel again in terms of family hierarchy and having any say about anything. And if they only have one, well, better have another in case something happens to that one. So they keep having babies, hoping for more and more sons. And I've already mentioned how the girls don't really go to school, or only for a limited time. They work very, very hard, but usually in the informal sector, so it's not very socioeconomically advantageous. If they've had a prior stillbirth or preterm labor, they're at higher risk for stillbirth. So stillbirth begets stillbirth, and it's really tragic when it happens over and over again in one family. Most of these women have absolutely no birth control options, so they have short birth intervals, and that again increases the risk. Most have maybe one prenatal visit, and it's a very cursory, you know, wait, and here's some iron supplement. That's kind of it. And as I mentioned, most do not give birth with a skilled birth attendant of any kind. So this pink area is the state of Chhattisgarh, and that's where I've been doing my research. It is a very rural state. The capital is Raipur. So to get there, it takes me about, well, between 36 and 40 hours from here, depending on whether it's rainy season or not. So usually I fly from Los Angeles to Delhi, and then take another flight to Raipur, and then take a jeep to where the hospital is. So it is very remote, and even within India, this state is considered a backward state. So they really need support. And I'm really pleased that this little bitty project has blossomed, and I'll tell you more about that. So in general, India has the highest stillbirth rate in the world, partly because of its high population, but the rate is also high. As I mentioned, the national rate is like 27 per 1,000, but that hides all those variances I talked about. But just for comparison's sake, in the US, the stillbirth rate is more like 2 to 3 per 1,000. So when a baby is stillborn, it's still a baby. And that's the part that has got to get through in the medical community in India. Because what I found in my dissertation research was that, this is just definitions from the World Health Organization. Sorry, I kind of got ahead of myself. So these definitions are difficult to apply in this context because they haven't had any antenatal care. So it's difficult to know exactly where they are gestationally. That's why the weight is a little bit more helpful. But you will find different definitions, and a lot of recommendations say to use 28 weeks for international comparison. And WHO does mention that as well. So you have to really pay attention when you're reading something about stillbirth as to what definition they're using. So this is from my dissertation. I did a mixed method study because there wasn't a lot of literature out there about this whole grieving thing. You know, my hypothesis was they're mothers, they grieve. I don't care where they are, they grieve. But I couldn't just go full bore and say so. So I started out with my qualitative, and those interviews were unforgettable. At first I was a little hesitant because I thought, oh, this is such a sensitive subject and I might be opening wounds, and what if just asking these questions causes harm? You know, that's kind of what was in the back of my mind. But I very quickly found that these women had never been able to talk about it and found it very cathartic. No one had ever asked them how they felt. Their families, their husband's family, tells them not to cry. They are expected to, the very next day, go back to work in the fields or cleaning the house or whatever. If they had a live baby, they're given a month or more to recover from the delivery and take care of the baby and so on. But if there's no baby, they're expected to go on like nothing happened. These women wept as they talked to me, but also expressed gratitude that finally they could tell somebody how it felt. And they would tell me things like, I see my sister-in-law with her 3-year-old bouncing on her knee, and I think, oh, my son would have been 3. I would have been holding him. You know, things like that. Or they would describe how they call the kicks and everything playing in the womb is the expression they use. And they would say, every day I would feel my child playing in the womb, and one day it stopped. And the grieving actually started then. They knew, even though they hadn't had an ultrasound or anything. Even then, they couldn't convince their family to take them to the hospital. So the grief was intense and very, very real. So to be able to document that was important. From the qualitative, the major themes was this overwhelming grief, the social norms of expecting to just go on with life and things like that, and a lot of gender and power issues. So then I went on to the quantitative portion of the study. I had 355 women participate. Half of them had experienced stillbirth and half of them had not. The perinatal grief scale is what I used to measure their grief on the survey, and that has been used internationally. The cutoff score is 91. On average, they were 111. That puts them at risk for complicated grief. So perinatal grief, when it's normal, is thought to last around 6 months. And of course, there's some depression with that and so on, but it resolves spontaneously, and they go on with life without forgetting what happened or forgetting the baby, but they're able to function normally. Whereas complicated grief can go on for years, 20, 30 or more years, and it's paralyzing. They have decreased function as a result of complicated grief. And I'll talk a little bit more about that later. We found that associated with this high level of grief, and some of them were much higher, remember that's the average was 111. So maternal age, number of living daughters, and emotion-focused coping increased their risk or were predictors of the high grief scores. So at least with my dissertation study, I was able to say, yes, they grieve. And I shared this with the local medical community. They were actually pretty open to it once I had the data. And it was pretty eye-opening. They immediately started saying, well, what should we do? And I said, well, I don't know. But as I was mentioning, the high levels of grief put them at risk for complicated grief. There was a lot of anxiety and depression, but anxiety and depression, any mental health issues are highly stigmatized in Indian society. And so a lot of the angst is pronounced in somatic ways. So lots of headache, lots of stomach ache, lots of dizziness, lots of can't sleep, you know, those kind of complaints come to the outpatient clinic, and the doctors are scratching their heads. They don't know what to do with these women. And so this, again, was really eye-opening to them that maybe they need to pay attention to that grief after all. They're also at risk for increased domestic violence. Domestic violence is really prevalent anyway in Indian society, particularly in the rural areas. If we used what we call domestic violence, it would be really, really high. But when you ask them, slapping and pushing and things like that, that's not domestic violence. That's just the way it is. So when they do identify domestic violence, it's severe. And unfortunately, women who have had stillbirth are sometimes abandoned right then and there. And a woman who's been married and then abandoned is almost, I mean, what are her options? Once in a while, somebody gets to go back to their natal kin, their family of origin, but that's unusual. Most of the time, they choose actually to stay with the husband's family as a servant rather than where are they going to go, you know? And then the family brings in a new wife to bear children or sons. So it's a very difficult situation. So I finished my dissertation research and came back to California and, you know, dove into teaching. But in my position, I was allowed to do research 1 day a week. Well, in reality, my teaching load was such that that meant evenings and weekends. But that's just the way it is. So my mentor that I mentioned introduced me to a researcher on campus that was doing mindfulness awareness for parenting stress. So her project is for parents of children with developmental delays on the autism spectrum. Those parents have extremely high stress. And MBSR, mindfulness-based stress reduction, is it's a manualized standard program with decades of research behind it that's very effective for reducing stress. I have to admit, I didn't really know a lot about mindfulness when I was introduced to this researcher. And I was thinking, kids on the autism spectrum and their parents, that's not really my area. But I needed to get my toe in the water. And she needed somebody to help her manage her grant. So I dove in. Wednesday nights, we did the program. We analyzed the results, all of that. So it was a really good learning experience beyond my dissertation in terms of everything you have to think about to do research, especially interventional research, which is exactly what I wanted to do. So even though it wasn't my area or my cup of tea, so to speak, it had value. And I'm really glad my mentor kind of pushed me that way, because I wouldn't have gone looking at that particular program otherwise. So meanwhile, I had to publish my dissertation findings. And thankfully, I was able to do so. I had 3 publications from that. And so if you're wanting to get into research, you gotta publish. Gotta. So this actually allowed me to get my own first small grant with seed funds, so I wasn't sure that really counted.
Everything counts.
Well, I wasn't going to be choosy since I was just starting out. So I got a seed fund of just under $6,000, and I was thrilled. So it let me go back to India. So getting to India is expensive. Once you're there, it's not so expensive. So you can do a lot with $6,000, especially if you have friends to stay with, right? So I did a feasibility study, because what I learned with that MAPS program that I joined was that mindfulness was really something I thought would be acceptable in India, because it makes use of the mind-body connection. And with the stigma of mental health, you can't just go in and say, well, you need counseling, or why don't you go see this psychologist or psychiatrist? Well, first of all, there aren't any. You know, there are a few in the major cities. In the rural area, there's barely a primary care physician, let alone a psychiatrist or psychologist. So I thought it might work, but as I mentioned, MBSR is a manualized, very standardized program. It requires 8 weeks, and the participants come for 2.5 hours once a week, plus a day-long retreat in the middle. And I'm thinking, is that doable? So I went and did this feasibility study, and I found that the women loved the concept, and they thought it would be helpful. I gave them just a little taste, little illustrations, verbally and so on. So they all said, yes, we want to do it. And I kept saying, are you sure you'd be able to come for 8 weeks in a row? And they were like, yes, we want to do it. So I said, okay, let's do one session this week, and we'll do another session next week. So had great attendance the first week, and the women were really into it, and I thought, wow, this is great. The next week, the monsoon came early. I couldn't even get to the village. They were all out in the fields desperately trying to harvest their crops before they were ruined. So I thought, okay, we'll go next week. And I was able to send a message. The next week, somebody in the village was getting married. Well, the whole village participates. So that wasn't going to work. So I had 1 more week left in my journal. Sweating, and I'm thinking, well, this doesn't bode well. But finally we got scheduled the last week I was there, and half of them came that had been there the first week. There were also some new ones that came who hadn't been there the first week. They had heard about it and wanted to come. But those that couldn't come sent messages. So a young girl came and told me, Auntie can't come because Uncle wants tea. So she had to serve her father-in-law tea, and that's why she couldn't come. Another one was in the field, another one had a sick child, you know, so on and so forth. So I kept notes of it all, and I also asked the women, okay, if we come back and do this for 8 weeks, when's the best season to do it? I got everything from January to December. No consensus whatsoever. And not only that, but there are certain, I mean, there's marriage season. That particular wedding I mentioned was a one-off, but there's a whole marriage season. There's monsoon season. There's Diwali season, which that's a major holiday that takes like a month to get ready for. And then, I mean, it's sort of like Christmas for us, you know. And so that wasn't good. I mean, it just, you know, and there are so many holidays. This area is primarily Hindu. In fact, 100% of my participants were Hindu women. And Hindus have more holidays than any other religion in the world. So finding a calendar that actually had the holidays on there was really tough, you know. So how do you plan? Well, I came back to the U.S. and I told my co-investor, I said, this is not going to work. There is no 8 weeks in a row that's going to work. I've looked at the whole year. There are not 8 consecutive weeks that'll work. So I went back to the drawing board, started looking at the literature again for shortened mindfulness programs. And it was really interesting. There were some that said 1 session is enough. Some said 4, some said 5, et cetera, et cetera. Well, the greatest consensus was around 5 weeks. So I decided that's what I would do. But I had to make some further modifications too. And in the meanwhile, I needed to publish some more so that I could get new funding. So these are some of the publications that came from the early part of these studies. And then finally, I was ready to do a pilot study. So I got a second small grant. This one was $10,000. And like I said, you can do a lot with $10,000 in India. So first I had to go back and train the local nurses to deliver the intervention because, I mean, I am working full-time here. I couldn't just stay there and, you know. So I trained the nurses from the hospital that I used as my base and in the mindfulness program. And I also had to train RAs to do the data collection and all of that. And we had to set up communication. I had to give them a computer so that we could Skype and, you know, at least the hospital has a cloud, so they do have pretty good internet. And so off we went, got started on this intervention program. So I really wanted to see if this would work, and I wanted to document the cultural adaptations, and I was hoping that since I trained the local nurses, it would also be sustainable. Oh, and in the meantime, over this period of time from my dissertation till now, the hospital started a school of nursing. So I helped them with their curriculum and stuff, and that's how I got plugged into the nurses who would be the best at providing the intervention. All those connections are really important. So, like I said, I chose 5 weeks, and I also adapted how it was delivered because it was just really hard for all of them to come. There, in each village, there is kind of a central meeting place that's used for multiple different things. Sometimes it's a banyan tree, sometimes it's an actual building, but there's usually one place where people gather for community things. But it wasn't available all the time, and the women had a hard time getting there. So the first week, I decided we needed all the women there so that I could introduce the program, get the basics delivered and all of that. But after that, home visits were how the local nurses followed up with each participant. Sometimes if they lived really close by, she'd meet with 2 or 3 of them, but most of them were one-on-one visits. Then group 4, we did another week 4, we did another group session because that was a crucial point for data collection for one thing. So I wanted them all doing it at the same time so that one didn't tell the other and so on. And then the last week was again home visits, and really that was primarily encouraging them to continue practicing the skills they learned in the intervention. And to be culturally fitting, we had an end of program celebration. So we had lunch, and each one was given a gift for completing the program. It was incredible. I wish what are those things where somebody is speaking in one language, but it's automatically translated in your ear to English?
Star Trek.
Like they use at the UN. I wish I had had that, because even though my RAs and the nurses were translating, I mean, the things the women said at the end of the program were so incredible, but I would have liked to hear it firsthand, so to speak, you know. Anyway, so in terms of the content of the intervention, we used concepts of mindfulness exercises. I used a lot of illustrations and discussion, culturally appropriate stories to illustrate the points. Most of these women are illiterate, so pictures and verbal is very important. And again, encouraging them to use daily practice to really own those skills, because the whole point is you learn these skills and you practice them every day when everything's fine, so that when there's stress, you can automatically kick in and use those skills. So the daily practice is really important. But I added a couple of other things: self-compassion and gratitude. An attitude of gratitude can be cultivated, and the literature shows that it is very beneficial to health. So I added that, and self-compassion I felt was really important because these women have such hard lives and they have such negative input from society. And they have a very fatalistic view most of the time that whatever happens, happens. But they also experience a lot of self-blame because, I mean, everybody else is telling them the stillbirth was their fault. So after a while, they begin to believe it. So, and then finally, there was an education component so that hopefully if they did get pregnant again, it would not result in another stillbirth. Mind you, some of these women had already had 3 or 4 stillbirths. So this is just a little context for you. So a couple of the nurses. So again, because the women are primarily illiterate, data collection, surveys, everything had to be done verbally, and so like a structured interview instead of an actual survey. And these are some of the, we did standing yoga. Yoga is part of mindfulness, but in this country, when MBSR is taught, people are laying on the floor, their legs are in the air, they're, you know, all kinds of things that would not fly there. So we did standing yoga. And this area here is where we actually ended up having our celebration. This was the home of the Sarpanch, which is the village chief. And so this was behind his house and a big open area where we sat and had our celebration lunch. So it was, and it's very quiet, you know, you're out in the middle of the fields. It's really quite nice in many ways. So then I got one more small grant. I wasn't expecting to do this, but with what I was just talking about, we did data collection pre and post and 6 weeks post. And I kind of thought that was going to be it. Then I got another small grant, so I was able to do a 1-year follow-up. So I had 36 participants in the 1-year follow-up. Some had moved away and other things. You can see their age and education there. The majority had a 1 to 5 grade education, but many had none. Most of them were not even allowed to go to the market without the permission of a man in the household. And even if they had permission, they never ever get to go alone. They have to go with a couple of sister-in-laws or the mother-in-law or a male. And the male could be younger than, it could be a 12-year-old boy, but he's a male, so it counts as a chaperone. And most of them said they were allowed to visit their natal kin, but only with permission. And that was only if they were like in the next village or something. This is just to give you an idea of the autonomy level that these women experience. I was glad to see that, so the bright pink, the bottom line is baseline, and at 1-year follow-up, they were, the upper line, they were making more use of facilities for birth. More of the babies were born at full term, more of them had antenatal care, and more of them had skilled birth attendant. So the education portion of the intervention had some effect. This is just kind of the flow of participants over the whole time. So these are really exciting outcomes. So HSCL is the health symptom checklist. It's a combination of anxiety and depression. And the cutoff score for that is 1.65. So at pre-test, you can see it was elevated. At 6 weeks, it had come down, but was still above the cutoff. And then at 1 year, they were within normal limits. The perinatal grief index, as I said, the cutoff score is 91. That showed a similar pattern where at pre-test elevated, 6 weeks come down but still elevated, and then at 1 year post within normal limits. Within the perinatal grief index, there are 3 subscores, and that's active grief, difficulty coping, and despair. And despair didn't come down as much as the others, and that makes sense because despair, it goes along with that complicated grief that's more entrenched. So SWLS is satisfaction with life, and as you can see, that increased a little bit, and it was statistically significant. SPS is social provision of support, and that didn't change much. And again, that's their perception of support from their mother-in-law, their husband, and so on. So they don't have control over that. But what's interesting is that these 5 measures of mindfulness were very telling. They learned to observe before reacting. And they learned to describe how they were feeling instead of letting their feelings run away with them. They learned to act with awareness instead of being on automatic pilot, just trying to get through the day, get through life. They also were less reactive. In other words, they were able to evaluate how they felt and choose how to respond instead of just reacting. And all of those were significantly improved statistically. Non-judging, that was a tricky one. that was a difficult concept to get across. And it's talking about internal judgment, you know, like when you get up one morning and you feel grumpy and, oh, I shouldn't feel that way, that's bad. That's judging how you feel instead of waking up, I feel a little grumpy today, what's that about? And going on with your day, you know. But the thing is, that measure was so full of double negatives that it was very, very difficult to translate. The concept was hard enough, and then with all the double negatives in English, it was very difficult to translate, even though I used the WHO standard method of forward and back translation, and I had Sanskrit scholars on the committee and everything, but they don't use double negatives in Hindi, so, or in Chhattisgarhi. So to try to do the equivalent when the English was in double negative, it was really hard. So I don't think that measure worked very well. But overall, they had improvements in mindfulness, and resilience tracked right along with mindfulness. And other studies have shown that too, that the more resilient a person is, the more mindful a person is, the more resilient they are in everyday life. And almost all of them continued daily practice of the skills that they had learned during the intervention. And I really credit that to why we had such good results at 1 year. This is a little depiction of the pictures that I used for the log. They kept a log of their practice every day. And again, because most of them are illiterate, pictures are very important. Yoga was their favorite exercise of the mindfulness skills that they learned. And in the evaluation, the qualitative piece was really nice because, as you can see from this word cloud, peace was the main thing that they described having gained from the intervention. So we went from extremely high levels of grief to them expressing peace. I don't think I could ask for better results than that. So you would think that this research program of study would, you know, just keep going and going and going. Well, nothing's that simple, right? So I put in for an NIH grant and didn't get it in spite of these fabulous results. And so in the meanwhile, I have, since I don't have funding to go back, I have been doing some local studies. So in Fresno, California, there's a large community of Indian immigrants. And I noticed while I was doing these studies in India that women, even who had not had stillbirth, had grief. And so I did kind of a little sideline on that and found that they grieve because maybe they haven't had any children. And we know how risky that is for them. They grieve because they've lost a live child at 1 year or 5 years or whatever. Some have had multiple losses, stillbirth and the loss of live children. And it's exponential. But it also was so tied up with their autonomy, or lack thereof, and the social norms, and the gender discrimination, and the pressures to save face for the family, and all that stuff, that I began to think, you know, some of that has got to come over with them when they come here. You know, you take the people out of India, you don't take the Indian out of the people, right? So I did a study in Fresno and found elevated levels of anxiety and depression among the women, not the men, just the women. And the patterns were interesting because women who only spoke Punjabi had higher levels of depression. Women who spoke English had higher levels of anxiety. And there were a number of different factors with that. And now currently I'm doing a similar study among Punjabi Sikhs in Riverside. Well, this was one of my participants who did the intervention, and at 1 year follow-up, in this picture, believe it or not, I mean, look how tiny she is. She's 7 months pregnant. And I did find out subsequently she did have a live birth, healthy baby girl. So in the US, there are, I hesitate to call them guidelines. There are things we do when a stillbirth happens in the hospital. But even here in the US, few women receive psychological support. I remember when I was a young nurse working on a neurosurge unit, and we had a woman who was admitted and miscarried on our unit. She wasn't there related to her pregnancy, but she miscarried on our unit. And I didn't know what to do. I mean, I was used to dealing with head trauma and everything else, and I didn't know what to do. Called the OB department, and they had a whole protocol, and they took care of it and everything. But that stuck with me. And I've looked at the protocols, I guess that's the word, protocols, because it varies from one institution to another. So nurses are encouraged to offer counseling. Now, what does that mean? Does that mean a referral to a psychiatrist or a psychologist? Does that mean you call the hospital chaplain? Does that mean you try to tell them everything's going to be okay? What does that mean? It doesn't say. And most often it only involves the mother. Well, there's a small slice of literature that includes fathers. Let me tell you, they're affected too. Differently than women. They grieve differently than women, but they grieve too. So why aren't we including them? So I went back to India and included men. But anyway, here we offer mementos. A photograph, a lock of hair, a baby blanket, various things. Here we also encourage them to see or hold the baby, but we leave it up to the parents whether they want to or not. The literature on this is very mixed. Some say it's helpful, some say it's detrimental. We give them lots of information about what might have caused the miscarriage or the stillbirth. But the fact is, even in this country, most of the time we don't know why. We cannot pinpoint the etiology. Now in India, it's usually right at the point of birth. So here sometimes it happens earlier, but in most third world countries or developing countries, it's peripartum stillbirth. But perinatal loss is miscarriage, stillbirth, or early neonatal death. We also offer memorial services or burial, that sort of thing here. All of that is mixed in the literature as to whether it's helpful or harmful, effective or not. There are some interventions available here, but it's inconsistent. And we don't have evidence-based guidelines. So what we do know is, as I mentioned, men and women grieve differently. Interventions have been aimed primarily at alleviating symptoms, not preventing the sequelae, not preventing the complicated grief or the depression or the PTSD, etc. Even though we have good predictors of complications, yet our interventions are not aimed at prevention. And inconclusive, as I mentioned, there are almost no RCTs. So what are we going to do? Well, I'd love to do an RCT, wouldn't you? That requires big funding. It also requires a substantial amount of preliminary data in order to get that funding. So what else can we do? Systematic reviews, meta-analyses would be very helpful. That's how we go about getting started to develop a guideline, right? And we need to focus on prevention, especially if the woman does go on to have a subsequent pregnancy. That pregnancy is often affected by the sequela of the loss. So we have a lot of work to do to develop evidence-based guidelines. And this is true of a lot of different topics in other vulnerable populations. So even if you're not into perinatal loss, that doesn't mean none of this applies. So vulnerable populations are those that are already at a disadvantage for whatever reason. They might be refugees, they might be immigrants, they might be from a minority group. Women across the globe are already at a vulnerable stance. Even here, we don't think so, but there are statistics that say otherwise. And of course, children, elderly, people with disabilities. I mean, the list could go on and on. But all of these groups are already at a disadvantage. So then when something horrible happens, whether it's perinatal loss or like the tsunami that wiped out fishing villages on the coast of India in, was it 2010? No, well, whenever that was. You know, so whatever tragedy comes along, they're already at a disadvantage. And they don't have what they need to help themselves when something that horrible happens. So these are the very people that we need to be helping. And as nurses, that's what we do, right? So there's a wide open array of research programs of study that need to be developed. And I hope that all of you will think about embarking on that journey. It's never dull, let me tell you. So thank you very much. And again, I realize women are not the only vulnerable population, but that's who I have focused on. So this was right after our celebration lunch, by the way. And most of the participants are showing in the picture. And that's me, in case you don't recognize. So, any questions for me? Yes.
So one of the challenges that we encounter in global health research is the approval process in different countries. So could you just describe the process of how you did IRB or any kind of ethical approval process? Did you have to involve the Ministry of Education or Ministry of Research in India?
So I had IRB from Loma Linda,
right,
because the mission hospital that I use at a base doesn't have IRB. Well,
okay.
They didn't then. They do now.
Okay.
But our IRB at Loma Linda made sure that everything also matched the ethical standards for India.
Okay.
And I had the Ministry of Health from the local area give permission before I started. And then each village that I went to, I had to get permission from the Sarpanch, the village chief. And then he would introduce me to the Anganwadi, which is like a women's village healthcare worker. Basically, she keeps vital statistics for the village. So she knew exactly which women had had stillbirth and so on, and she would introduce me, and it would kind of snowball from there.
And did you have the same approval process when you publish your data? Did you need to get an approval process from the Ministry of Health?
Yeah,
you do.
yeah.
Okay.
I always bring my findings back
Right.
to the community before I publish.
Before you publish it. Okay.
Mhm.
Okay, thank you.
And the hospital now, through our USAID grant, has developed a mobile clinic that's going out to the villages to give prenatal care, and that's how they have kept this intervention going while they're out in the village. Mm-hmm.
Question. What do they do with the baby when the baby's born stillborn? Like here in the States, we do so many things at that time for the mom and the
Yeah.
parents, but do they just whisk the baby away
Mhm.
and that's it?
Yeah, and usually the women have not even seen the baby. Hindu women are not allowed to view dead bodies. So it doesn't matter whether it was an old person or a newborn, they're not allowed to view dead bodies. Sometimes they would tell me, I saw the baby's foot as they took him away, or, sometimes they didn't even know what gender the stillborn had been. But the husband or his family members will take it away. And they do bury the body, but without any ceremony, any recognition, and it's like it never happened.
So since they can't view the dead body, would any of these interventions ever be put to place there? They wouldn't be allowed at all then?
They would be allowed mementos. So like if the family had brought a special blanket to put the baby in, but a lot of times they just don't have anything like that. They are so poor that they're just planning to wrap the baby in whatever cloth they're using for whatever, And like I said, the evidence here is so mixed anyway. I'm not sure I want to transport it over there and try to contextualize it, because I don't want to do that if I don't have solid evidence that it is helpful. Yes.
Well, I want to thank you for this presentation.
Thank you.
Your view on vulnerable populations and global health is right in alignment with where the college graduate nursing is going. And so this is a great talk and great timing for us. So I really appreciate your expertise and your skin in the game. So not only are you doing research, but you're doing it globally and you're doing it well. And I love the fact that you did a mixed method. So I can see that you're more of a quantitative researcher than qualitative, but you still kind of honored the women's stories and allowed them to speak, and you helped them have voice. So that's wonderful. My question had to do with religion, but you answered that. So most of these were Hindu women versus Muslim women.
Yeah, I mean, there are a few scattered villages that are primarily Muslim, but they don't really mix very much. And like I said, all of my participants were Hindu.
It's this is now just my political bent, but it's too bad what's going on in the government right now, because I know USAID has really been narrowed. And there's not as much funding out now for these kinds of studies as there was like 5 years ago. But I have hope for the future that perhaps in the future this funding will open up again, and there'll be more opportunities for us to do these kinds of things.
I hope so.
How did you get introduced to the Ministry of Health in India?
My friend is the director of the hospital, and he has to interact with the Ministry of Health, so he introduced me.
So that's how that.
Yeah.
Good job.
Did you get any resistance from the communities, kind of like family members?
So the informed consent is an interesting process there. Here, we want each individual to make up their own mind. It doesn't work that way there. The women ask their family if they can participate. The family reads the informed consent, or one of us reads it to them or whatever. Then they discuss it. If they give the nod, then the woman reviews the informed consent and signs it.
Do you think a lot of women were not allowed to participate?
I know for sure of one in my very first study, my dissertation study. We were at her home. She was wanting to proceed when her husband came home from the field, and he discussed it with the mother-in-law, and then they decided no. So we left. And that was interesting because, you're in their home or their garden or their field or whatever, and yet the mother-in-law wants to hover nearby, and I wanted them to be able to speak freely. So a lot of times I took my daughter with me, who is a amateur photographer. And so she would kind of distract the mother-in-law and children and so on by, oh, look at this beautiful garden, let me take your pictures. And, so things like that are helpful. you can't do it secretly, you can't do it in private, because then there's no trust. They have to be able to see you, hear a few things, but I didn't want them to be right there, so.
I have a non-research related question. So what led to your growing up in India?
My parents were missionaries. My father was a professor, and my mother taught English and violin.
So did you ever learn any of the language?
So we moved around. That made it difficult. We started out in, I should bring them back. We started out in Maharashtra, which is in the very center of India. And there they speak Marathi. So when I was little, I knew enough Marathi to play with my friends. But then we moved to Chennai. Back then it was called Madras, which is in the south. There they speak Tamil. So then I learned enough Tamil to go to the market and things like that. Then we moved to Serampore in the north near Calcutta. There they speak Bengali. So nope, I didn't learn anything fluently. And plus the boarding school I went to was an international boarding school, so we had to speak English. So I have to have a translator when I go out to the villages. In the city, you can get by quite a bit with English. Not at the research level, perhaps, but in terms of just getting around, you can get by with English, but not in the villages.
You were readily accepted by the children in the neighborhoods where you were out and you played with them.
Yeah, and you know, it does help to try to fit in culturally. So that's why I was wearing a sari. In that area, toe rings on the second toe mean you're married, so I wore those. You know, I wouldn't go anywhere without my bangles. And you know, you have to have your earrings on, and you know, and you don't look men right in the eye, and you know, you know how to conduct yourself, and then you know, they see that you're trying. Obviously, you're a foreigner, but if they see that you're respectful and trying, they're very welcoming.
Any other questions? Well, on behalf of the college.
Thank you.
And I hope you'll come back and talk about what you're doing with the fathers.
I'd be happy to.
Okay. We do